Hello, everyone, and welcome. My name is Sarah Holman, and I'm the Clinical Product Marketing Director here at Riverside Insights. I'd like to thank you for taking time today to join us for our webinar, Best Practices in Early Childhood Screening, a Case Study Approach. We're excited to welcome you today to learn the importance of early screening. During the presentation, please leave any questions you may have in the Q&A box. A recording of today's presentation and certificate of attendance will be sent to all registrants. The recordings from our previous webinars can also be found at our website. And now, without further ado, I'm going to hand things over to Beth.
Hello, everyone. Thanks so much for coming. Let's do a quick introduction of me, and then we're going to dive in and chat about preschool assessments, particularly screening. So, like was mentioned, my name is Beth Varner. I was born and raised in Alaska. I stayed there through undergrad, and then I moved to Seattle to do a school psychology training program. I worked as a school psychologist in Anchorage, Alaska, in the Seattle area, and then down in Los Angeles County. And as a school psychologist, I've been in preschool all the way through adult transition. So I've seen a little bit of everything and have definitely spent time assessing young students like we're here to talk about today. So I have the experience in my back seat and back pocket, and I know some of the challenges that we're going through. And today, what we're going to talk about is kind of how the ways that preschool assessment and the role of screening might have changed in recent times. We know that the COVID-19 pandemic has and continues to have a gigantic impact on all of our lives. And when we think about preschool screening, we think about early childhood assessment, this is going to be a big component of what we're thinking about and what we're talking about. So today we're going to talk a little bit about some of the impacts that we see on young children as a result of growing up during the pandemic. Obviously, this is all very new data. There are some good studies that are out there that I've got cited for you here, but this is an evolving area. So we're going to talk about what we know so far. Then we're going to talk a little bit about the role of screening tools. And I think in the context of this unprecedented event of the pandemic, I think that the role of screening tools is even more important and can help us kind of sort through what might feel like an onslaught of referrals. And then we're going to look at a few case studies and what that might look like, how we might move forward, how we'd look at scores, and the information we can get from a screener. So let's talk for a little bit about impact of the pandemic on early childhood development. Again, what we know so far. This is all as of today's date. This is what we know. This is what the research community is sharing with us. So when we think about, first, let's talk a little bit about infants and babies. Infants that were born maybe during the lockdown stay-at-home period of early pandemic pre-vaccinations, or maybe infants that were born more recently, but are still, kind of in the context of ongoing behavior change due to the pandemic. When we think about infants and babies, what we know is that, especially during that stay-at-home period, there was reduced exposure to family members and family friends, maybe other families with similar age infants outside of the immediate household. We also know that due to susceptibility to illness, there may have been a significantly less exposure to older generations of the family, whereas in the past, maybe grandparents or other older caregivers were more part of young children's, infants, and babies' lives. We saw that reduced when folks were doing more social distancing and more caution around older folks. We also know that all of the pandemic from the beginning to now, and especially during the time that it was more of a stay at home, uh, with the exception of essential workers time, we know that stress was very high. We know that depression and overwhelm was very high. And we have good data throughout history that parental depression, parental stress really has a huge impact on infants and babies. They're very aware of it. The home environment might be altered and things might feel a little different at home than they might have were they born even a few years earlier. We know that using masks created a scenario in which we mostly, with the exception of kind of clear options, we mostly only saw the upper halves of faces. And while it's great to do that for safety, we also know that infants and babies are very drawn to smiles. We have lots of historical data that shows that an adult smile, a human smile, is very drawing, very engaging to a baby, and is something that they really respond to. And so having fewer people in their life that they were able to see their full face definitely could have a potential impact on the individual's development, socially, and even like visually. We also know that early, especially early stages, that some babies were immediately quarantined from their birthing parent, especially if the birthing parent was COVID positive, which has so many impacts. We know that, feeding is not just, the physical process of nourishment, it's also a big bonding piece. And having that immediate separation, we can all imagine could have a pretty significant impact on those early days. And in the two sides of every coin category, we know that the research that is being done now is reporting that a lot of families report increased family togetherness, especially during those kind of stay-at-home phases of early pandemic. And as we all experience, there are some great sides to that and there's some difficult sides to that. It may be the case that infants were less likely to go to daycare, spent more time with their immediate family and caregivers, and we can see how there could be some real benefits. We can also see how that setting was a cause for stress and overwhelm and anxiety on behalf of the parents. So this is really, there isn't a good or bad quality here. There's a lot of different pieces, but infants definitely spend a lot more time, for the most part, around family than they might have if they were born during another time. Let's spend a little bit talking about toddlers. So what we know about toddlers is that everything that we said on the previous screen is likely an impact there. So depending on the age, of how old they were during, kind of those early pandemic stages, we know that family time at home, probably less engagement with peers, less engagement with older family members, all of that is definitely true. What we really see in toddlers coming in is a significant increase in screen time. We know that prior to the pandemic, most pediatricians advocated for some limits on screen time, particularly for young children. There has been a lot of studies throughout, the time that we've had screens everywhere, showing different effects throughout the span of childhood. But just by nature of this stay-at-home time and what parenting was like, and continues to be for some folks, a significant increase in screen time for a lot of toddlers occurred. So in some of the data that has been collected in this, kind of time since the stay-at-home period, we know that generally, not even just related to the pandemic, but we know that generally children under the age of 2, screens are not a great way for them to learn. When teaching a young child new activities, new things to do, modeling it in person versus modeling it through a screen has a stark difference. We also know that when we're thinking about early developmental pieces, particularly language, particularly these social components, it really, that in-person time, the peer collaboration time, the peer play time, the peer engagement is a key part for how these things develop. And for some or many toddlers during this time, that was dramatically decreased or not available to them. We have data that indicates that preschoolers that have 2 hours or more of screen time daily have higher rates of behavioral problems, delayed developmental milestones, and lower vocabulary than children with lower amounts of daily screen time. That this isn't to imply causation, but we know that there is some effect there, that whether it is spending more time on the screen is contributing to these, whether it is the life circumstances that results in spending more time on screen causes some of these. That's not necessarily what's being claimed here, but it's just a matter of, we know that having any scenario in which a toddler is spending a lot of time on a screen does correlate with some of these different outcomes. And also, we know that screen time at age 3 is predicted of anger, temperament, frustration levels at screen 4 again, or sorry, at age 4. Again, you know, questions around what the causal effect is there, we don't exactly know, but we definitely know there's a correlate there. And we as adults definitely know that screens have an impact on our eyes, thinking about the fatigue, the disruption in our sleep and circadian rhythms with blue light. Imagine how susceptible a toddler can be for these things. So all of the kind of emotional engagement, family pieces that we talked about on the previous slide, as well as the real increase in screen time for toddlers, results in us being in kind of a different place when we're thinking about early childhood. We're looking at how we're going to engage with these pandemic babies, as they're often called, moving forward. So what do we expect to result from these things? What do folks that are working in preschool often report, preschool or early childhood? Increased rate of referrals, more folks saying, I don't know, I think there might be a delay here. I think that this child looks different. That is certainly something that we hear reported from the field. We also hear more parent or caregiver concerns regarding development, wondering what was the impact on my baby or toddler? How did this experience impact their development? How do I make sure that they catch up, as it were? And we also hear like daycare, preschool teachers making observations about maybe developmental patterns or behaviors looking a little bit differently than they might have in the past. So what do? I've kind of set the stage here with, we know that our early childhood group has had a very unique experience that, you know, certainly in the modern times where we've been doing what we've been doing as, you know, assessment professionals and supporting students in education, this is all new territory for us. And I think that one of the pieces that can be really helpful to assist us in meeting this moment is early childhood screening and getting some data around where students are, where they're at, what next steps are. So let's talk a little bit about the role of screening in early childhood, some of the benefits of screeners, and I'm going to introduce you to the one that I'm talking about today, which is associated with the Battelle Developmental Inventory. So if you're not familiar with a screener, what a screener is a more brief, more broad version often of an assessment or type of assessment that is looking, it's essentially looking for red flags, right? If we were to think of a comprehensive assessment as one that goes very deep in however number of areas that we need to assess, what a screener lets us do is take a broad brush to this student and get a sense across different areas how they're doing and really inform our need for further assessment, further data collection. So a screener is an efficient method of gathering objective data about development in a wide range of areas. They let us make data-based decisions about a child's development and whether they need comprehensive evaluations, interventions, etc. A great thing about a screener is that it can really reduce caregiver anxiety. Like we said, we have a lot more parents and caregivers coming to Child Find, coming to their pediatrician, coming to whatever it is, and just saying, I don't know, especially parents of, where their pandemic baby is their first child. Is this normal? I don't know. If a child or an infant during that phase of time where everyone was social distancing more, the parent or caregiver didn't have that frame of reference that often occurs in mommy and me groups or playtime or time for folks to get together, because it's really valuable. Those gatherings are important, not just for the child's development and all the reasons that we talked about previously about social and language and learning from each other, but it's really important for parents to be able to see and calibrate what's the range of expected behavior for my child. When I was in the schools as a school psychologist, that was always kind of the back pocket trick, right? And many school psychs report this. If you're working with a parent who doesn't seem to have a good grasp on particular deficits that their child might be experiencing, or doesn't understand how much it impacts them or is different from where they should be developmentally, one of the best tricks is to have them volunteer, to ask if they'll volunteer in the classroom, and spend a little bit of time. Because when you are with your child and your child is all you know, of course, for the most part, you're going to assume, yeah, this is the way all, for example, third graders look and act and behave and engage and focus and concentrate, etc. But you walk into a classroom of third graders, and again, there's obviously ranges of human development that is totally fine. It's not that we want every single kid to look the same and act the same. That said, comparing a child to other children, understanding kind of the dynamics of that group and where they fall in with each other is a really important way of learning about your child. And so having reduced having reduced access to that for some of the pandemic might have resulted in, kind of more caregiver anxiety around, I don't know what I'm looking at. I don't know if this is okay. Is my kid all right? And also, what we know for screeners is that it gives us some good strengths and weaknesses data. And this is really important whether or not the student moves forward with a more comprehensive assessment. So oftentimes we think of, okay, we're going to do this screener and it's going to let us know whether or not you need to do a complete evaluation. And if the answer is no, you don't need to move forward with a complete eval. Sometimes the instinct might be to kind of push the parent out the door, like, nope, your kid's fine, no need to move forward, move on with your life. If you do that, I think we're kind of missing an opportunity, however, to take the data that we have, because even though if the kid shows up as, no, we don't need further evaluations, when we're hitting multiple areas of development in our screener, we're going to see strengths and weaknesses. Maybe they're all normatively average or above, but we're still going to see that the student might have higher scores in one area than another. And having the opportunity to chat with parents about that, even if they're all normatively average, can really personalize the experience and help the caregiver know their kid better, which is really important. So when I'm thinking about screeners, when I'm thinking about what kind of screener I want to use and what would be the best for my practice, I'm thinking about a few different topics here. One is a quick and efficient administration. I want to be able to get a good amount of data in a short amount of time so that I can screen multiple children, right? Generally, we use screening as kind of everyone who walks in the door. Sometimes it's we're going to screen the whole preschool class, or sometimes it's we're going to screen everyone that shows up and ask questions about Child Find, or whoever it might be. We're typically doing a broad amount of children. So in order for it to be feasible at all, it needs to be an efficient process. I also want the evaluation that I'm using and the screener that I'm using to cover a wide age range. I want to be able to, ideally, I want to be able to use the same tool on as many individuals as possible. Some of that's for efficiency, right? If I just have to learn a tool, if I just have to learn one or two assessments and I can get a lot of information from a lot of different folks, that can be really helpful for me to be able to work efficiently, understand my tool, get very good at giving it, which we know helps with the confidence that I can have in my results. I'm kind of a numbers person. I'm a psychometrics person. That stuff is something that I keep track of and feel very, I don't know. It's what the reason I became a school psychologist is because I love the assessment and data piece of it. And so for me, I'm trying to find a co-normed assessment whenever possible. I want to be able to have a source of information where I know that if I'm measuring my students in a number of different areas, that those different areas, the data that I'm measuring them against, the population group that I'm measuring them against was the same whenever possible. And that's something that I think, we all know is best practice when we're thinking about assessment, but is also just very important to me to make sure that I can have the most confidence when presenting my results. I'm also looking for, but can't always find, but another piece that I'm really looking for is flexibility in administration and response modalities. That is one of the features of the Battelle, and that's the reason that we're talking about that today. But this is really, if I'm sitting down with a third grader to give a cognitive assessment, I expect for that entire test to be, I'm going to sit down with a student, ask them a question or show them a task and have them respond. This kind of direct administration of information. That makes perfect sense. But when I'm in early childhood, it can be a whole different world, right? When we're working with young children, yes, sometimes we can ask them to do things. Sometimes that's not an option, particularly for assessments that can go all the way down to birth. And so having the flexibility to get my data a number of different ways is something that I really value and is one of the things that leads me to the Battelle. And we're going to see examples of that in a minute, but it's something you don't always find in early childhood assessments out there, and I personally find to be a huge benefit to the process. So to get ready to talk about case studies, all the case studies that I'm presenting today show the results of the BDI-3 developmental screening test. You might hear it as the BDI screener or the Battelle screener. So I want to give you a couple kind of hit points on that so that you're familiar with it, so that when we move on to show the results page, you can see, you have some context for what we're talking about. So what the BDI screener does is it hits 5 areas of developmental milestones. So you get some data on social emotional, communication, adaptive, motor, and cognitive, kind of the big 5 in early childhood. And what the BDI gives us is the ability to assess birth through 7-11. So I have this breadth of age that I can use the same tool Obviously, with basals and ceilings, I'm only going to be giving a number of questions to each individual child, but this really kind of meets that standard of I would love to have one tool that measures the broadest range possible so I can really get into it with this tool and understand it inside and out and make sure that I have very strong confidence in my results. And what I love about the BDI, as I mentioned before, are these flexible administration options. So there are up to 3 different modalities of administering each item on the test. Not every item has all 3. They have as many as are appropriate. And the 3 categories or the 3 types are a structured assessment, what we might think of as kind of that giving a 3rd grader a cognitive assessment that I was referring to before. Observation, which is such a huge part of data collection in early childhood, and then parent or caregiver interview. So what this looks like, I'm just going to show you a quick example so you can kind of imagine how that might be. Here's an example of the social emotional domain on the BDI-3 for an item that is for children. This is the first item in this area that starts at birth, right? Birth through 11 months. This is our initial question that we're offering. And what we're trying to measure with this item is the child smiles or vocalizes in response to adult attention. And as you might imagine, with that task, there are a number of different ways that I can find out that information. So I can do a structured assessment model. I can follow these instructions to when the child is contented, lay them on their back, lean over, smile and talk or sing to the child, nodding your head, don't touch. So this is kind of a direct, you engage in this behavior and see how they respond. That version of, block design or whatever you might do with an older child, right? Another method of doing this is observation. What we know as early childhood assessors is that during our time, particularly if we're assessing with a multidisciplinary team, during our time with the child and their caregiver and whatever assessors might be supporting us, we're going to see a lot of things, and it may not require, okay, I'm going to lay you down on the blanket and be 12 to 15 inches and try and engage with you in this way. It might be the case that just in the time that we're together, there will be a period in which the child is being given adult attention, and we can notice whether or not they smile or vocalize in response to attention from others. And if we see that during our time together, we don't have to set up another scenario to see if it happens again. We can see, oh yeah, no, this is something that we've seen this child engaged in. I can answer this information. And then the third modality, because, because when we're talking about early childhood, we really rely a lot on parents and caregivers. Our third modality is asking these structured interview questions. So we might need to ask the parent, how does the child respond to attention from adults? For example, does the child coo, babble, smile, or squeal? How often does the child respond in this way? So regardless of the style or setting or way I'm engaging with the child and their parent, I'm going to be able to get the information that gives me this, the response to this item. So that flexibility is really kind of a key piece of the BDI. The next thing that you should know that can be something that makes the BDI stand out is the ability to have multi-point scoring. Because what we know about early childhood is that acquiring skills and developing skills is not always a yes or no thing. It's not always either they can do it or they can't. I mean, heck, that's true with adults. I can kind of change my oil. If I watched a YouTube video first, I could probably do it. I've done it before. Would I ever confidently walk out somewhere and say, yes, I can change my oil? Probably not, because I need some support, right? There's kind of a range in which we all have skills. And so, particularly in early childhood, having the ability to not just say yes or no, they do this or they don't, but saying, okay, for child smiles or vocalizes in response to adult attention, that typically 90% or more of the time, yes, they do this. Sometimes I've seen them do it less than 90%, but they do it sometimes. Or no, this rarely occurs or never. It allows me to really get some data on both emerging skills and skills that have been firmly acquired. And then a really important part here is the broadness of examiner qualifications. We know that the BDI is often given in multidisciplinary teams that include preschool teachers, school psychologists, SLP, OT, etc. And having really an understanding of development and assessment and spending some time specifically making sure that you understand the basals and the ceilings and the administration procedures, because it is standardized assessment. But the flexibility for the makeup of your multidisciplinary team is a really big drawing point to the BDI. So now let's talk a little bit more about specifically the BDI screener, and then let's look at some results. So again, birth to 7-11, we talked about that. And when we talked about screeners before, we talked about we're trying to do, a mile wide and inch deep. And I don't say that to minimize the value of the data that you get, but we just don't have time to do a comprehensive assessment on every single kid that walks through the door. We have to find a way to sort folks out. And as we know, we have to have data and documentation as to why, particularly children that we're not moving forward with a comprehensive evaluation, we have to be able to justify that very clearly. And that's what a screener gives us, is the ability to do that. So the BDI-3 screener is made up of 100 test items from the developmental complete. And the BDI-3 developmental complete is the full assessment. It has all the domains and subdomains, and it's much more in-depth. It's where I would go if a student shows up as needing more evaluation. But the screener is just a broad sense. There's about 2 items each for each of 8 different age levels across those 5 domains. And it gives me, this screener gives me kind of 3 different types of information, 3 different levels of analysis, if you will. And I want to show you a couple examples of those so you'll be ready to interpret them for our case study. So the first thing it gives us is an overall score. In my practice, I don't find myself using this a lot, this kind of total screening score. For me, I really care much more about the individual domains and strengths and weaknesses and what are low and what isn't, in the same way that using a full scale IQ, or especially like a complete total achievement score, we don't find ourselves using those as much in practice. We're really looking at strengths and weaknesses, but in scenarios in which you need one, or maybe your state documentation or your district documentation requires one, you do get a total score. Where I really find myself using this data is getting the different domain scores. So if I do a BDI complete, the developmental complete with all the different subdomains, I get domains and subdomains and really granular detail. But for the screener that I'm doing for efficiency's sake to see whether or not I need to move forward with more assessment, I'm getting an overall score for each of the different domains. And that's going to let me know, based on this source of data that I'm going to use in collaboration of all the other sources of data that I'm collecting, whether or not I'm going to move forward with additional evaluation for this child. And the third kind of method of data, the third type of information that we're getting, is this kind of skill level mastery descriptors for the different domains. So if I, as the evaluator, enter the item level scores into the digital system for the BDI that we're not talking about today, but if I enter that item level score, I can get some item analysis to hand to the parents and caregivers. And this is such an important part. Again, even for those kids who are not moving forward with services or evaluation, or, kids that we're saying, nope, we don't need to do a further child find process or whatever it might be. This is so important. Being able to hand a parent, here's some details about what they can do, what they showed as an emerging skill, and what is going to be what we call a future learning objective, right? So here's some examples in the communication domain. So this child that came in was able to communicate using simple sentences, understand simple action verbs, and understanding what and who questions. Those were indicated as mastered. And so being able to tell a parent, yeah, they've got those ones. When asked to repeat familiar words with a clear articulation, that was a more inconsistent. That was, probably a 1 on that 0, 1, 2 scale that we looked at a minute ago. So this is something that they can do sometimes, but is still emerging, probably needs some support. And responding appropriately to yes or no questions, or using yes or no appropriately, was something that they weren't able to do. So that's indicated as a future learning objective. When we don't have the time today to really do a skills analysis on these children in the case study, we're going to be looking at their broad scores like these ones. But when I'm actually, working with kids and have more than our short time together today, I'm not only, getting the overall scores and talking about the different domains, I'm really looking at these skills and looking for patterns and what this skill analysis might tell me. Because, I obviously have notes from the day when I assessed, I have information about what it was, but the caseload of a typical preschool assessor is often very high. We're working with a lot of students, and we may not always remember exactly the nuances of every single assessment when we go to write our reports. But something like this can be a huge trigger for, oh yeah, I did have kind of some articulation questions about this student, and their ability to repeat familiar words made me wonder about, is there a receptive issue? Is there an expressive issue? Where is this falling down? So this kind of step-by-step piece is really awesome. I wanted to highlight it, even though we don't have time to talk about it today. But that's one of the reasons that I really choose this assessment. And of course, we've kind of been talking about this throughout. The primary use of a screener is to determine, are we doing more assessment? The main reason that we do it is, do we need more information? Screener data in and of itself is, I would say, all the places I've ever worked, insufficient to move forward with eligibility decisions. I need a more comprehensive assessment that looks at these domains in more depth before I just say, oh, yep, let's move forward with services or interventions. So that's really kind of how we're using that screener, is to route us towards the next step in supporting this child. And the next step after a screening is often either, continue on your way, we don't need to do further assessment, but here's some information about their strengths and weaknesses and their skill mastery levels. Or, yeah, this is a child that we need to dig in, do the full developmental complete, and get more information about. All right, let's look at some of these students. So the data that you saw when I was showing you kind of examples on the previous slide was for Melissa. Melissa is 4 years, 11 months, and 9 days at the date of assessment. And I want to use Melissa's scores to kind of explain how I'm reading this and what information I'm getting here. So the raw score is obviously Melissa's raw score, how many points she got correct in each of these domain areas. The standard deviation is the level of significance that I choose when scoring these results. So often your overarching, whether you're working in a hospital setting, in a school setting, there's going to be some guidance as to what level of significance we consider a deficit to be, moving forward. So for example, I mentioned that I did my school psych training in the state of Washington, and I practiced in Washington for a while. And in Washington State, in order to use the developmental delay category that we have available as a disability category under IDEA, the criteria was that the student needs to be 2 standard deviations below the mean in 1 or more of 5 areas of these, the 5 developmental areas, or 1.5 standard deviations below the mean in 2 or more. So if you're 2 standard deviations below in 1 area, or 1.5 standard deviations below in 2 or more areas, then we would, move you forward, because we would likely assume that what we see on the screener, we're probably going to see in the developmental assessment, but that's why we're doing the screener, is to move forward and see whether or not we need more information. So for Melissa, if I'm looking at that, let's say that I'm using that kind of standard, or I'm working in a setting where 1.5 standard deviations is what we're using for significance, then this column is going to tell me the cut score for this level of significance. And then if a student score is above the cut score, then we say we don't need to move forward for additional assessment. They don't have a statistically significant normative weakness in this area at the statistical significance level of 1.5 standard deviations. If, however, the child's raw score is at or below the cut score, then we say we need to look at more information in this area. And I want to, again, repeat that it's at or below. So for example, for Melissa, her social emotional raw score was at the cut score. So we know that her social emotional skills are about probably 1.5, maybe a little bit more, but kind of depending on how the norms work out, but at about 1.5 standard deviations below the mean. We can guess that Melissa's adaptive scores are much, much lower, because in order to be just 1.5 standard deviations below the mean, she would have had to have 20 points, and she only got 10 points. So we would see, if we reran this with a -2 standard deviation level of significance, adaptive would still ping as a refer, but social emotional wouldn't. So that's kind of how we're using, depending on the setting that we're working in, depending on what kind of standards we're measuring our students up to, is the level of significance that we're going to use. And then this is how we're going to make that comparison as to whether we move forward. So with this profile, where I see multiple areas as well as the full scale, again, I don't always use the full scale, but it is kind of something to see whether it supports your case or not. What I see here is that this is a child that I would move forward with. So what I would do in this setting is that I would move forward and do the BDI developmental complete with my multidisciplinary team. I'd be using that comprehensive evaluation for my final eligibility determination. But what informed me that it was necessary to continue on with more evaluation was my screener. And I would guess, based on the scores we were just looking at, that our results is going to likely indicate a global developmental delay. Again, we need to get the comprehensive information before we know that for sure. And as school psychs and other evaluators, of course, we would never presume to know the answers and the outcomes of our evaluations before we do them. That said, at some point in our career, we get fairly good at kind of knowing where things are going for the most part. And as long as we say, oh, stay open to being wrong, then that can be helpful information. So were I just seeing those screening scores, I would guess that Melissa would be heading towards diagnoses that indicates a global developmental delay. All right, let's look at Henry. Henry is 2 years, 10 months, and 26 days. Henry is referred by, this was recent, so again, referred a child that was born in late 2020. Mom is worried about what's going on and what his development looks like. And he seems like a 2-year-old bordering on 3, kind of from first look. But again, to support the parent, to have some data about what are next steps, how do we want to move forward, we did a screener to get a broad sense of kind of where he's at and what's going on. So when we're working with Henry, our first look is at this 1.5 level of standard deviation as the level of significance. So I'm looking for, does he meet, for example, 2 different areas of 1.5 if you're working in a system that requires that, or just across the board, some evaluative systems use 1.5 as the level of significance. So when I look at these results, I'm thinking, this kid's probably going to be a speech evaluation, right? Like that's probably the referral that I'm going to move forward with for Henry. And he needs, these other areas look okay. In fact, many of them are at least a point, if not several, above this standard deviation. That said, I'd probably glance at my my total score and see, yeah, he's looking a little bit low across the board. If my cut score is 75 and he has a 71, but I really want to know how much of it is made up of this communication piece and how I want to move forward. So in my case, what I would do is rerun this. It's a couple clicks to rerun this with 2 standard deviation level of significance. So when I run this again, I see that communication still pings as an area that we need to refer. So not only is his communication skills more than 1.5 standard deviations below the mean, we know that it's actually 2. In fact, it's probably about 2 on the nose because he hit exactly that cut score. And so this is likely going to depend on the state that you're in and kind of how you would move forward with this evaluation. But I could see going one of 2 ways. One could make the argument, and I think this is the argument that I would make, is that Henry still needs the developmental complete. Yes, I know that only speech showed up in his as a for sure, at the cut score, etc. But if we go back here, this is kind of one of those places where I can see some of the benefits maybe of a total screening score, where the difference here, he's so close to hitting the cut score in so many of these areas that across the board, it shows that he's like right on the edge of 1.5 in many areas. And then obviously we know 2 below or more in communication. So I would argue for let's do the full with this student, because when we dive into these domains in more detail, I might have more information about what's going on and might see that he actually does meet criteria in a few different areas. I could also see some folks might make the case to just do a communication evaluation, and maybe that uses the communication domain from the BDI or other tools that an SLP might use. I could see that as being kind of, if they don't signal at 1.5, that they need more evaluation in those areas, we don't do it. But I think were I in this situation, I would, push forward with, let's get a little bit more information about him across the board, because he's just hanging on to the edge of that cut score for these other areas. So we're likely going to see a speech language delay. I think we can predict that with pretty high degrees of confidence. Whether or not we're going to see some delays that meet eligibility in the other areas, I don't know, but at the very least, would he be potentially a good candidate for, enrichment type intervention? Likely, yeah. All right, and our last student here we're going to talk about prior to taking a few questions is Jessica. Jessica's a little older than our other students. She's 5 years, 8 months, 9 days. And when we do the BDI screener with Jessica, what we see is 2 areas, both the adaptive and the cognitive, being 2 areas where she meets that 1.5 standard deviation below the mean criteria. So, and these 2 areas being adaptive and cognitive, I automatically kind of have the intellectual disability question in my head, right? As to this might be where this is going. So for this student, were I in a system that I needed to hit 1.5 or even 1.5 in 2 different areas, I would move forward and do a comprehensive and get more information. That said, because it's so easy to look at this with a number of different criteria for significance, I would look at this also to see kind of how severe these are. And when I rerun this with 2 standard deviations as my level of significance, I see that both of those areas that I'm concerned about are even that far below. And so my spidey sense that's saying maybe we're talking about an intellectual disability here is even stronger at this point, particularly because it's an older child. And so I know that we're doing more structured assessment, more kind of hands-on activities. Just out of curiosity, though, I also wanted to look at the 1.0 level of significance. You're rarely going to find a system in which 1 standard deviation below the mean qualifies for services, etc. But it still gives us some interesting information. And I didn't bring this 1.0 for Henry, the last child, but I would be curious what it was. So let's look at Jessica at the 1 standard deviation below the mean. So of course we already know that adaptive and cognitive are going to fall in the refer because we know there are 2 or more standard deviations below the mean. So of course they're 1. But she's right at the cutoff here for 1 standard deviation below the mean in social emotional and has fallen below for her total score. So we can really see that even the social emotional that was kind of hanging on the edge there at 1.5 level of significance, she still is experiencing some deficits there. Again, ID is what's on my brain. So Jessica is a student that I would 100% refer for BDI developmental complete or other preschool assessment with my multidisciplinary team to look at potential eligibility determination. This is a student that is likely heading towards special education services. And I would guess that depending on where I live and what categories are available to me, I would guess that an intellectual disability category, or if I live in a state where I can use developmental delay, I would guess that that would be where we're winding up. So in summary, everyone uses this word too much, but it's accurate. The unprecedented experience of the pandemic impacted every part of our lives and had a very significant impact on the growth and development of all children, particularly the very youngest. As a result, as a component of that, we're facing a resulting increase in referrals. And screeners are a really good way to allow us to efficiently determine which children we're going to move forward with a comprehensive evaluation, because we know that a comprehensive evaluation we can have the most efficient tool in the world. It still takes time. That's inherent to comprehensive. So using a screener to get us through the little bits of information, to give us guidance as to how to move forward, it can be a huge time-saving tool. And we're going to use the results of the screener. I mentioned this once, but I can't underline it enough, in conjunction with other sources of data. We're talking about assessment today, and so I focused on assessment scores, but all of us should know at this point, and I know you do, we're never using scores in isolation as a single point of data to make decisions. We're looking at our caregiver report, daycare or preschool teacher report, all of our pediatrician information, et cetera, and making decisions with a comprehensive data set. So results of the screener is going to drive the next steps in evaluation, which will help us efficiently route children to necessary interventions during these critical development periods, right? Because we all know that if a child, particularly an infant or a preschooler, needs intervention, we need to get it to them as soon as possible, because that will increase the efficacy. So we have a couple minutes left. If any other questions, or if any questions have come up, we can take some of those. And if you don't have any questions, feel free to go. Thank you so much for your time. And feel free to reach out to us, the organizers, if you had any questions that you wanted to ask individually.
Thank you so much, Beth. We didn't have any questions come through, but I did want to, and forgive me if you've touched on this, can you give a ballpark of time for administration? I know it's going to vary by age and ability level, but more or less, how long would the BDI screener take to administer?
Yes, I had that in my notes and I didn't say it out loud. Thank you so much for saying that. So any assessment that is birth to 7-11, there is no one answer to that question. That said, 5 to 10 minutes per domain-ish is a good ballpark. Again, a lot of it's going to depend not only on the age of the child, but also kind of how much information you have going in. And this is always true, because the more accurately you can predict the correct starting point means the more efficient your basal and ceiling process is going to be.
And can you use this screener? Do you have to administer the entire screener, or can you administer only certain domains?
You could do certain domains. I think that the brevity of it, I would argue that in almost every case you should do the whole thing just to get a more comprehensive picture. But no, you could do certain components. Okay, I see a question here.
Yep.
Oh yeah, go ahead.
Are there sections of the screener that can be administered with a tablet?
Yeah, and that's the piece that we didn't really kind of get into today, are the component or kind of the mechanics of the BDI-3 screener. But yes, what's awesome about it is that there is a digital app that you can use on iOS, Android, and Windows. And when you have that up, the questions and all of the little screenshot that I showed you today is all like directly on your tablet or tool. And you might have other manipulatives, you know, like because they're the little kids, you might have to give them a block or a toy or something, but your tablet can be there to collect the data. Each person on your multidisciplinary team can kind of be collecting their own data, or you can do it all together, however you want to do. But yeah, the digital implementation here is really easy to use, and I personally prefer it. I always have a backup paper protocol in the room somewhere, just in case, maybe I didn't charge my device the night before or whatever. But I find what I really like about the tablet and computer administration is it calculates my basals and ceilings for me. So I'm not finding 3 zeros or 3 ones or whatever to before I know whether I need to move on in the chaos of the students.
And last question before we go, is the screener a separate purchase from the full assessment?
It can be if you would like to just purchase that, or I personally, the price difference is so similar that I think getting both, if you're going to use them, both, and one flows into the other so easily. But yeah, you can just do the screener, or just do, there's a third component, the Battelle Early Academic Survey. If you're trying to do academics on 3-6 through 7-11, you can do just that component too.
Okay, if we currently have the full assessment, does the screener come with?
My understanding is no, because it's been a minute since I've done this, Sarah. You'll have to clarify for sure. But no, because you need to at least get the protocols or the test book or the digital test records, to be able to have just those specific items. So it would be a pretty small addition onto the complete.
Yeah, I believe, and again, I'm not 100%, but I think it's 200 and something-ish dollars to add the screener to the developmental complete.
Yeah, it's a pretty small one, and you're going to be so familiar with the assessment already using the full that it'll be so easy to kind of pick it up and start using it.
Absolutely. Well, excellent. Thank you again, Beth, for the amazing information, and thank you for our attendees for coming today. We're out of time, but please be sure to stay tuned for other professional development opportunities coming up. If you get the recording and a question comes up, please don't hesitate to reach out and we will get an answer to you. And have a great rest of your day. Thank you, everybody.
Thanks, y'all. Have a good one.